disease? What are the options? So what are the clinical evaluation you can do to find out peripheral arterial diseases? Anyone? Any takers? Someone kindly unmute and respond. I'm happy to get very nice answers from you all.
So the patient will complain of claudications, intermittent claudications history could be there. And on physical examination, the peripheral extremities can be cold, and also peripheral pulses, if we feel for, they will be feeble or either absent.
Very good. Okay.
That's it.
So there is a three things I would like to tell you about this. You have correctly mentioned that there will be a history of intermittent claudication, or there could be on clinical examination you will get a absent pulses. So what are the pulses we need to see? What are the pulses for peripheral evaluation you want to see?
So in the peripheral pulses, we look for in the upper limb, radial artery, brachial artery, and in the lower limb, femoral artery, popliteal artery, dorsalis medius, and posterior tibial artery.
Okay, so suppose uh, right and left radial arteries are absent, lower limb there is absent, maybe dorsalis pedis, bilaterally absent dorsalis pedis. What are the things you will think of?
Sir, if it is a young male, then Berger's disease could be the first differential, and in an older patient, atherosclerosis could be kept in the differential.
Very good, very good. What about suppose our current patient? Suppose this patient has absent bilateral dorsalis pedis. Then what will you think?
So atherosclerosis, because he's a diabetic as well, and diabetes increases the progression of atherosclerosis than a normal individual. So I would keep that as a possibility.
Okay, that is fair enough. So basically, what we have to do, so you have the clinical situation is, so you have a patient with diabetes with a history of maybe some heart failure. That's why he is breathless, but he is having a bilaterally absent dorsalis pedis. Next thing that we need to do is to examine for other pulses. So since the background is there, your answer is probably correct. It is probably because of atherosclerosis. But one important concept we should all understand is that whenever you feel that there is an absent pulse, always check bilaterally. If there is a right absent dorsalis pedis, check for right left also. Then you check for bilateral posterior tibial also. Then you check for popliteal also. So there is an absent bilateral dorsalis pedis, then there is high chance that it is a physiological absence of bilateral dorsalis pedis, because up to 30% of the patients can have bilaterally absent dorsalis pedis or posterior tibial. Both won't be absent, otherwise foot will get gangrenous, but it can be physiological absence of either dorsalis pedis or posterior tibial bilaterally. It will never be unilateral absence of these arteries. So always check for symmetry, right absent, check for left absent. If left absent, then it could be a physiological absence. Then you need to check further. If all other pulses are normal, then it can be a physiological absence also. Okay. So apart from that, so these things that you have told, these things we have to examine. Apart from that, to confirm clinically, okay. So these are symptomatic wise claudication will be there. There may be a cold. If it is acute limb ischemia, it may be cold. But if it is a chronic limb ischemia, then it may not be cold. It can be a normal because collateralization is there, so it may not be cold also. But absent pulses may be there. So basically, to confirm, what we need to do is something called as, you already know, ankle brachial index, right? So if the ankle brachial index is less than 0.9, it is highly suggestive of, it is very specific for peripheral arterial disease. So if anyone can answer me, if suppose ankle brachial index is more than 1.4, then what could be the possible explanation for that? What if the ankle brachial index is more than 1.4? If less than 0.9, then it is PAD.
1.4 means calcification or diabetic.
Exactly. That is true. So Anu has answered. That is a correct answer. If it is calcified or atherosclerosis, so that can cause a increased ankle brachial index. So suppose you don't have a BP cuff, then what will you do? How will you diagnose a peripheral arterial disease without a BP cuff clinically? Anyone has an answer?
You can check for CRTs,
You can check for
capillary refill time.
capillary refill time. So yeah, it can also give a fairly good idea, but like monofilament. So actually, if you go and read Harrison, there is one very interesting study they have mentioned in which they have told that if you check saturation of upper limb and lower limb, and there is a difference of more than 2%, then it is very sensitive, as good as ankle brachial index in diagnosing peripheral arterial disease. So a pulse oximetry, simple pulse oximetry test, and a difference of more than 2%, but it should be a good quality pulse oximeter. Otherwise, it's difficult to answer. So in an authentic pulse oximeter, if the difference is more than 2%, we can call it as a significant finding for peripheral artery. Okay, so we can move forward.
Okay, sir. Coming to personal history, is on regular diet, bowel and bladder habit normal, sleep and appetite is reduced since 1 week. There is history of smoking since the age of 25 years, 5 to 10 cigarettes per day, average pack year is 8, no history of alcohol intake, no history of any vaccination in adult life.
Okay, any so all these answers we should have. How much smoking is dangerous? When will you call it a smoker? So a person who has smoked more than 100 cigarettes in his lifetime is called a smoker. And you should know how much is the safe level of alcohol for CAD, for liver. There is no safe dose of alcohol, but for cardiac diseases, there are some studies. One large study was their inter-heart study. So they have mentioned some criteria up to what level. So up to 25 to 30 grams of alcohol can be less than that can be safe, they say, but we don't know the authenticity of the study. Don't take encouragement from such kind of studies. Yeah, so you can go forward.
Okay, sir. Coming to family history, there is history of diabetes mellitus in both his parents. Father died due to diabetic kidney disease, and he was on hemodialysis at the time of death. One of his brother is also having diabetes mellitus. And socioeconomic history, upper middle class family.
Okay. So Mr. Dr. Nuruddin sir has mentioned 30 ml. So whenever we talk about ml, no, we need to discuss about what is the like spirit that we are using. So 30 ml of different uh, alcohol varieties will have different amount of grams of alcohol. So we need to calculate in that manner, because it is an important question, may be asked in the examination. So we should know the conversion rate, how much alcohol content is there in different kind of alcohol. Okay.
Okay, sir.
Right. Okay. So you can summarize.
So 47-year-old male, non-case of diabetes mellitus with history of diabetic foot and right fifth toe disarticulation and peripheral neuropathy, and a chronic smoker with factor of 8, presented with complaints of palpitation, which was class 2 on exertion since 2 months, orthopnea and fatigue since 1 week, and sudden onset heaviness of chest pain. Heaviness of chest associated with worsening of the breathlessness to class 4 since 1 day. There is no history of fever, cough, abdominal pain, reduced urine output. The probable system involved is cardiovascular arrest.
Okay. Anyone, sir, anyone else want to ask any question from this summary? Anyone has any doubt or any clarification or any question for this one? Okay. So Dr. Tinto has mentioned 21 units for men and 14 for women. That is per week. That is the correct dose of considered safe units of alcohol that we can take. Okay. So summary. No one has any questions, any doubts. Anyone want to ask questions first? Any seniors want to ask any questions? Okay. So we will move forward. So we will go to the examination part.
Okay, sir. Coming to general examination, he was moderately built and nourished, conscious, cooperative, oriented to time, place, and person, anxious, sitting in the bed, thin hair spine normal, pallor present, bilateral pitting pedal edema present, no cyanosis, clubbing, lymphadenopathy. Pulse
So
was 112 beats per minute.
can there is there a possibility of cyanosis in heart failure?
So can I continue?
Can a patient with heart failure have cyanosis?
Can have, sir.
Why they will have a cyanosis?
Sir, in case of chronic heart failure, when there is hypoxemia, there can be increased EGF and increased proliferation of some. You're asking about cyanosis, sir?
Yeah, cyanosis.
When there is hypoxemia, there can be cyanosis, sir. Reduced,
Yeah.
Increased deoxygenated hemoglobin level will lead to cyanosis.
So, like basically, what we need to understand is, so if there is a normal functioning lung and there is some defect in heart, so hypoxemia as such will not cause cyanosis. It definitely may contribute, but only hypoxemia will not contribute to cyanosis. There is something else which may precipitate cyanosis, and that is, see, the for heart failure, patient with heart failure, the driving force is sympathetic overactivity. So, because of sympathetic overactivity, there is peripheral
It's a peripheral
vasoconstriction.
vasoconstriction.
Yeah. So there is more extraction of blood O2 from the blood, then it will cause a cyanosis. So that's why we need to understand that it will always be a peripheral cyanosis. It can never be a central cyanosis. Okay, if a heart failure is causing cyanosis, it will always be peripheral. It will never be central until unless there is a shunt lesion between right side of the heart and the left side of the heart. It will always be a peripheral cyanosis, right? I
Yes.
think we need to speed up.
And coming to vitals, pulse rate 112 beats per minute, regular, low volume, normal character, no vessel wall thickening, no radial or radiofemoral delay, all peripheral pulsation palpable except bilateral posterior tibial artery. JVP just seen above sternal angle in 45-degree position. BP was 90-60 millimeters of mercury, left arm sitting position. Respiratory rate 28 breaths per minute, saturation 90% in room air.
Okay, so in this you have given very nice findings. So there is a lot to discuss about pulse and JVP. So anyone want to have more discussion about pulse here? Anyone want to give more information about pulse? What kind of pulse? So suppose she is giving a clinical diagnosis from her history and summary that there is some probability of heart disease, maybe some airway dysfunction. So what kind of pulse do you expect in a patient with heart failure?
Pulses alternates.
Pulses alternance could be one possibility. So what other kind of pulses you can expect in patients with heart failure? What will be the character of the pulse? Anyone? Low volume, yes. So that is fair. So it will most probably be a low volume pulse. Okay, and there could be a pulses alternate. So why there will be a pulses alternate? Water hammer pulse. So Dr. Anand has told that it could be a water hammer pulse, could be a missed. Dr. Nikita has told could be a missed beats. So that is possible. So if there is a arrhythmia, there could be missing of beats.
Irregularities.
That is possibility. Uh, Water hammer pulse actually is more specific in cases of aortic regurgitation. So, but still, if a patient with aortic regurgitation has developed LV dysfunction over a long run, because there is peripheral runoff. Because why we get a water hammer pulse is when we have a peripheral runoff. So, if there is a AR which has developed a LV dysfunction, they may have a water hammer pulse. But basically, it is a low volume pulse. One classical pulse which is defined is pulses alternance. So, why there is pulses alternance? See, as a PG student, when you people were MBBS student, you have to tell answer of all these questions. Whatever we are discussing, you have to tell the answer to these questions. When you become PG, you have to tell why for every question. So whatever answer we have to have a why for every question. And if you begin to ask yourself why for everything, you will be a very bright, you all are bright student, but you will be beyond the sky bright student, right? So what happens in pulses alternance, no? So basically what they mention is if there is varying sensitivity for intracellular calcium. So for cellular contraction, for cardiac contraction, there is calcium is needed. So when there is already a dysfunctional, tired myocardial cells, myocardial filaments, so they have a varying sensitivity for calcium that is there inside. So one beat, what will happen? It will be a very good contraction, and then it is tired. It's not ready for the next contraction. So the sensitivity for calcium is varying, and every alternate beat it gets some energy and contracts very nicely. The alternate beat, the next beat, it is not that powerful. So that's how we get a pulses alternance. So how you check for pulses alternance is you have to check for the beats and you have to check for the pulse simultaneously. So if there is a discrepancy between these two, there is possibility that there is a pulses alternance, okay, which is classical for
Yes.
LV dysfunction. It can also be seen in conditions like pericardial tamponade. So there is a rocking movement of the heart inside the fluid cavity that is there, and it will sometimes it will come and bounce into the pericardium, and you will get a pulse beat. So you can auscultate it there itself, right?
Yes.
Okay, so what about JVP? What kind of JVP will you expect in this case? Failure of electromechanical coupling. That is also true. So basically, the reason for electromechanical coupling disturbance is it is because of calcium, varying calcium sensitivity. Dr. Manmohan has told. Okay. So what about JVP? Can I get some answers? What kind of JVP will you expect?
So raised JVP if there is right heart involvement also.
Mhm. Okay. So suppose you are not able to get JVP, you are not able to see JVP. What will you do? And you
Make
are,
the patient in 45-degree position. If we are
okay.
not able to see in sitting position.
Yeah, that is true. So basically, what they say is, if JVP is just visible in sitting posture, then it is called as raised. If it is not visible, then make him 45 degrees. Still not visible,
Sir,
then
hepatojugular.
exactly. So everyone is writing hepatojugular reflex. I think you all need to check. I think it is hepatojugular reflux rather than reflex, right? So how will you do? Anyone can come forward and tell me how they will do the hepatojugular reflex. How to check hepatojugular reflex? Anyone is there to come forward? We don't have much time. Please come fast.
So we make the patient lie in 45 degrees. Then we press the right hypochondrium, press it for 10 seconds. And usually the JVP will rise and then will fall within 3 seconds, because the right heart will accommodate within those 3 seconds if it is a normal heart. But in case of a failing heart, the JVP will sustain, that rise in JVP will be sustained for those 10 seconds. That will be a positive hepatojugular reflex.
Okay, that's a very good answer. Just I raised this question to clear one misconception we all have during our study period, is that we have, it's actually called as hepatojugular reflex, but we don't need to press in the right hypochondrium. Okay, because what the mechanism of hepatojugular reflex is, we are basically pushing the splanchnic blood into the right side of the heart. So where is the splanchnic blood? It is lying in the abdominal area. The splanchnic circulation, splanchnic veins will have all the blood in the abdominal area. So we have to basically press in the periumbilical region rather than the right hypochondrium. Right? So the pressing part, because already if the patient is in congestive cardiac failure, they may have a tender hepatomegaly. So you will make the patient feel more pain if you press the right hypochondrium. That's why it is basically we have to press in the abdomen. Rest of all your definition was correct. Okay.
Yes.
Right. So Yasmina, you can go forward. So we have many things to discuss. I think we can keep on discussing in subsequent classes. So we can go to BP and other things.
Yes, sir. There was hypotension, tachypnea, and desaturation, sir.
Okay, right.
Most
So
probably due to decompensated heart failure leading to pulmonary edema and desaturation, tachypnea, and hypotension also, sir.
okay. So BP is low. There is 90/60. Uh, Okay, so basically we have to check all the four limbs BP at least for first time. For all patients, we need to check for orthostatic hypotension, because you
Yes.
told patient is diabetic. There could be some autonomic signs of diabetic neuropathy. So autonomic neuropathy that you need to check. So for all patients, whenever you are checking for the BP for the first time, it should be at least bilateral upper limb, at least one lower limb. You should always check for orthostatic hypotension, and you should always check for something called as POTS. Anyone can tell what is POTS?
So postural orthostatic tachycardia syndrome.
Yeah, exactly.
It is that when the patient stands, because of he feels the heart rate increases. That is because of peripheral pooling of blood. The heart needs to work more to supply the blood to the peripheral organs.
Correct. So is it normal or abnormal to get tachycardia?
Normally it will be less than 30, sir. If it is more than 30, it is abnormal.
Correct, exactly. So normally it should, the rise of your heart rate should not be more than 30 per minute. But if it is going from baseline more than 30, or overall heart rate has gone beyond 120, then we consider this as postural orthostatic tachycardia syndrome. So in recent scenario, this spots has become little more highlighted because of COVID. So the patient with post-COVID syndrome very frequently used to have this postural orthostatic tachycardia syndrome. So that's why we need to know what's. Okay, it has got equal importance as so autonomic nervous system of any patient you can check by orthostatic hypotension or POTS, or very importantly Valsalva maneuver. Okay, so there are some indexes that we use in Valsalva maneuver that we need to study for diagnosing autonomic neuropathy. Valsalva maneuver with Valsalva exercise is very important diagnostic tool for diagnosing the autonomic neuropathy. Okay,
Yes.
right. So your
Stability test also assess this
tilt,
autonomic dysfunction, right, sir?
yes, tilt table test is also very good. Anyone can tell how do we do tilt table? Okay, we discuss this later. We can go to further. We have to finish your history in 15 minutes.
Okay, sir.
8:30 is our deadline. We have to finish in next 12 minutes.
Okay, sir. Coming to cardiovascular system inspection, JVP just seen above sternal angle in 45-degree position. He appears to be central. Chest wall is symmetrical. Apical impulse visible in left fifth intercostal space, just lateral to the midclavicular line. No dilated veins, scars, no other visible pulsations, no precordial bulge. In palpation, all inspectory findings confirm, sir. Trachea central, apex with palpable at fifth intercostal space, just lateral to midclavicular line in the left side. No palpable pulsation, trill or parasternal wave. Percussion, right heart border corresponds to right sternal border, left heart border corresponds to apex, and left second intercostal space was resonance.
Okay. So,
Auscultation, S1 and S2 have all four areas. S1 best heard in mitral area, no S3 or S4, no murmur, no carotid bruit.
so better you finish your history and then we'll have some discussion and then we can finish.
Respiratory system, everything was normal except there was bilateral basal crepitation, sir, and all other system was normal, sir.
Okay. You can finish it. Full history. So this is your diagnosis. Okay,
Yes.
before diagnosis, we will discuss some things.
Okay, sir.
Okay, come back to your inspection and palpation. Okay. So I would like to ask the students. So basically, okay, you finish your diagnosis also. Let us discuss.
Okay, sir. Diagnosis, this is a case of cardiovascular system with acute decompensation of a chronic heart failure, most probably precipitated by acute coronary syndrome in the form of acute myocardial infarction. Patient currently in sinus rhythm in NYHA class 4 due to macrovascular complication of diabetes mellitus with anemia and peripheral occlusive vascular disease.
Okay. Right. This now. So she has mentioned that it is a case of chronic heart failure. Okay, and because of that, there was some shortness of breath for 2 months, palpitation for 2 months, and then this patient ended up in some acute coronary event. And after that, there was because of that he ended up in NYHA class 4, which was a baseline class 2 symptoms. Okay, so my question to the students is, what is the uh, what is the probability that this is only a acute coronary syndrome, or this is a heart failure? I am telling no, I am not satisfied. This is a rheumatic heart disease, and this is totally not heart failure. Is there anyone who wants to agree with me? No one is ready to agree with me. Okay. So actually, this patient, what happened to this patient? This patient had a uh, acute coronary syndrome was not there. Patient had a chronic rheumatic heart disease. Okay, in the form of uh, aortic stenosis, which was there for throughout his life. Which after in the adolescent he got a acute rheumatic fever, which got converted into chronic rheumatic heart disease. He developed aortic stenosis with mitral stenosis. There was double valvular involvement. Patient had subtle symptoms. Okay, and patient had recurrent palpitation because of some mild MR he was having, and patient landed up in uh, acute exacerbation of uh, all these symptoms in last 2 months with the development of pulmonary thromboembolism, which presented through which the patient presented like this. Can this be like this? What are the points?
So there was no childhood history of fever.
There is no history of fever. That is fair enough. So the next question comes: is it possible to have chronic rheumatic heart disease without acute rheumatic fever?
No, sir.
Yes, sir. In case of streptococcal skin infections, also patient can land up having.
Number one. Number two, very important thing to understand is that up to 30% of the patients with chronic rheumatic heart disease have no clinical history of acute rheumatic fever. They had, but they had a subclinical rheumatic acute rheumatic fever. So patient had rheumatic fever, but they could not be diagnosed of acute rheumatic fever. They don't know. Patient had some simple fever, and they could not be diagnosed for acute rheumatic fever. So they can have a subclinical acute rheumatic fever, which turned into chronic rheumatic heart disease, which turned into AS. So what is against this?
Sir, in this patient, if it was due to rheumatic disease causing MS or MR and leading to heart failure, it was highly likely that the patient will also have atrial enlargement and can have atrial fibrillation, sir. So in examination, pulse was regular and there was no signs of any other valvular heart disease, sir. So I think it is less likely.
See, this regularity of pulse, this is a very important thing to understand because you have not seen the ECG. Okay, so what are the conditions in which a patient with AF will have a regular heart rate?
On
So,
drugs.
on drugs, very good. So, they can be intermittent. The patient can be on drugs, patient on
Yeah,
digoxin.
paroxysmal AF.
So patient can have a paroxysmal layer. So you won't have a feeling of irregular heartbeat. Secondly, the most important thing which is against the diagnosis of chronic rheumatic heart disease is the timeline. So see, uh, so Dr. Sala has told beta blocker. So on drugs, uh, patient will not have the symptoms of heart. Patient will not have these classical presentation. Secondly, that all the rheumatic heart disease has a very prolonged retractable course. So patient with AS will never end up in acute onset symptoms within 2 months. Okay, so you must have heard that Braunwald series, the famous Braunwald series, in which they mentioned that for AS to develop congestive heart failure or death, they will have a very prolonged history of angina, then syncope history will be there, and then dyspnea history will be there. So angina will be there for 532. You must be knowing this. So 5 years of angina will be there. Then recurrent syncope history will be there for 3 years, more than 3 years, and up to 2 years of dyspnea will be there. Then only patient will end up into this kind of serious trouble. So basically, we should always know for all the common diseases that we read, and for MS, it is even more. So MS progression is even slower than the aortic diseases. MR is even slower. So out of all the rheumatic diseases, the regurgitant diseases are more having a better prognosis. Okay, they have a very long course, not a very short course of 2 months. So my point here is we should always know of the very common diseases. We should always know what is their incidence, what is their prevalence, and what is their natural history. So the natural history of rheumatic heart disease is very long. It's not short. So out of these diseases, what are your differential diagnoses? What is you have told that it is a congestive heart failure with acute onset of MI. What are your differential diagnoses, and why you have kept this diagnosis as your first diagnosis?
So one thing is those risk factors, diabetes with complication, uh, with diabetic foot ulcer and disarticulation history, and peripheral neuropathy history was also there, sir. And he's a chronic smoker. So it is highly that high chance that he will have a atherosclerotic vascular disease. So I thought of uh, acute coronary syndrome worsening the heart failure in this patient, sir. And in case of acute heart failure, most common cause is acute myocardial infarction. So I will consider it as the first differential diagnosis, sir.
Okay. So why not? Because the patient is a diabetic, and diabetic patients are very prone to develop dilated cardiomyopathy. because of the deposition
That
of
can
the
also be there, sir, because the apical impulse was little shifted to lateral side, sir. So that can also be there, sir.
Can it be pericarditis? Why it is not pericarditis? I am telling that this is chronic constrictive pericarditis.
Pericarditis, from the history, the chest pain was not like a pleuritic pain, sir. It was heaviness of the chest, but still we cannot completely rule out.
So one thing which is very much against pericarditis is the classical history of orthopnea. So the pericarditis, chronic constrictive pericarditis patient don't have a typical history of orthopnea. So it is very important to understand is that ischemic cardiomyopathy, dilated cardiomyopathy patient present as left heart symptoms before the right heart symptoms. So earliest to present, even in fact it is told that PND is a very early symptom of ischemic cardiomyopathy, but it is a very late symptom of conditions like restrictive or a constrictive cardiomyopathy. Similarly, a patient with constrictive cardiomyopathy or a restrictive cardiomyopathy will have right heart symptom much before than the left heart symptom. So you are telling a history of orthopnea. So a constrictive cardiomyopathy patient will never have a symptom of orthopnea so early in their course. Okay. So CCP is ruled out. Heart failure, again, if it is a dilated cardiomyopathy, it will have a long course. It should not have a short course. And uh, secondly, one important thing to know here is that the incidence. So, there is one very famous registry. What is the most important heart failure registries in India?
Sir, Trivandrum Heart Failure Registry.
Yeah,
And there is
very
some
good.
National Heart Failure Registry.
Correct. So, this Trivandrum Heart Failure Registry is one of the most important heart failure registries done in India, done in Sri Chitra Tirunal by Dr. Hari Krishnan sir and others. So, what is the important inference that we got from this study was the most common cause of heart failure in India is ischemic heart disease. So, like incidence wise also, if 100 patients of heart failure are there, 70% of the patients are of ischemic cardiomyopathy. Rest 10 to 15% patients are of dilated cardiomyopathy, and the rest all are rheumatic heart disease and CCP and hypertrophic cardiomyopathy. This could very well be hypertrophic cardiomyopathy also. So chest pain history can be present in patient with hypertrophic cardiomyopathy also. AS also there could be a presence of chest pain. Okay, so so anginal chest pain is a very typical finding in patient with AS. What is nocturnal angina? Can anyone tell what is nocturnal angina and what condition you can get a nocturnal angina? So patient has typical chest pain only during lying down and sleeping. Anyone? Nocturnal angina? So nocturnal angina, yeah, Trivandrum registry, Dr. Anvaya has told. Carotid pulses in JVP will increase, that is correct. So pericarditis is also increasing. So Dr. Harika has asked what is pro-BNP role in CHF. So it's a very good question. So actually pro-BNP previously, all the heart failure studies, you must have heard second year pharmacology, Framingham heart failure study. It is one of the very important heart failure registries that was done, Framingham heart failure registry. So that time they did not use pro-BNP, but all the current guidelines, including the European Society guidelines, American Society guidelines, to diagnose systolic or diastolic heart failure, they have made a criteria of using pro-BNP. Pro-BNP of more than 300 is one very important diagnostic criteria for heart failure, especially for diastolic heart failure. With echo findings, only if there is a rise in pro-BNP level of more than 300, then only you can diagnose this as heart failure with preserved ejection fraction. So that's very important. So what is nocturnal angina? Nocturnal angina uh, is seen classically in patient with aortic regurgitation. So when a patient lies down, since the patient has very high cardiac output because of the regurgitant lesion, there is increased preload again, and the load to the left heart increases too much and the coronary circulation is not capable enough to supply blood to the myocardium to overcome this. And you know, the biggest heart is in AR only. AR will have a very big, huge size of heart. So in this case, what will happen? The patient will have a nocturnal angina. So it is seen in AR. So let us get the closing remarks from Dr. Jasmina. She will finish up by telling why she is telling that this is a case of congestive cardiac failure, typical ischemic cardiac. You want to tell ischemic cardiomyopathy, right?
Yes.
So, okay, let us finish by discussing what will you do to this patient immediately and long term within 2 minutes.
Okay, sir. Can I discuss what we have done in this patient or what we will do in general?
So, if what you have done and what has to be done are different, then it will be very not good scenario.
Okay, sir. Okay. In this patient, first we have connected the oxygen master, and then we have we have secured two IV lines. Then we have taken chest X-ray, ECG first, then chest X-ray, and we have collected sample for ABG also, and we have sent sample for TROPI and basic investigation, CBC, CRP, electrolytes, RFT, sir, along with LFT also. Then in the chest X-ray, it was suggestive of pulmonary edema, and we have started him on NIV and BiPAP, and in the ECG, it was NSTEMI, sir, and troponin was also elevated. So we have given loading dose, then shifted the patient for coronary angiogram once the orthopnea was settled. And then he was treated before coronary angiogram. He was treated with diuretics and evaporating since he was having tachycardia and all. Then after coronary angiogram, he was pretty stable, and we discharged him with dapagliflozin, beta blockers, aspirin, clopidogrel, atorvastatin, and OAD set. In addition to that, we have also added furosemide 10 mg OD set. We have not started ARNI and MRA because on evaluation he was also having AKI, sir. So we have not added that.
Okay, okay. So I think that is fair enough. Very good presentation. Very happy with it, and very good participation by our dear students. I congratulate them all, and I think we will continue this kind of discussion in future as well. Thanks a lot, everyone.
Thank you, sir. Thank you so much.
Thank you. Thank you so much.
Thank you, sir.
Thank you,
Over
Dr. Nigesh, sir, for the nice class over here.
Over to Dr. Mithun for the closing remarks. He's the secretary of Spice Route Kerala chapter. Over to Dr. Mithun.
Good evening, everyone. We had an interactive session on cardiovascular system. I think this is one among the best session we had this year. We almost had 100 participants in this session. So I would like to convey our gratitude towards Dr. Abhishek Tiwari for chairing this session and making this session as an interactive one and guiding us all through clinical insight on cardiovascular system. Thank you, sir.
Thank you so much, sir. It was nice to be with you.
I would like
so
to
much.
appreciate Dr. Jasmina for her effort to make an effective session. Thank you, Dr. Jasmina.
Thank you,
On
sir.
behalf of Spice Route Kerala chapter, I convey our gratitude towards all family medicine residents and faculties who attended this session. Thank you all. We will hopefully come up with another session next month. Thank you.
Sure, sir. Thank you so much.
Thank you, Dr. Mithun. So that's all for today. Good night, everyone. Hope to see you all next time.